All right, welcome everyone back to another virtual shouting session at Hearts for Health. We're excited you could join us. Hopefully y'all are enjoying the rest of the summer. It's off to a start, to say the least. But today we're joined by Dr. Kittleson. She's a professor of medicine at Cedars-Sinai and director of education in heart failure and transplantation at the Smith Heart Institute over there at Cedars-Sinai too. I do have a quick few reminders before we do get started though, if you are new particularly. And just quick two things. The first thing is about our Q&A at the end of these sessions. So if you're unfamiliar with our format, we do have a Q&A at each one of these sessions, and that's reserved towards the end. You can just type in your questions in the chat and we'll read them out to our speaker, to Dr. Kittleson in this case. And that's really all for the Q&A. We do it with any time that we have remaining, but usually we'll have a good 10 to 15 minutes towards the end. So as we go through, as Dr. Kittleson goes through her presentation, feel free to type in any questions you have for her about the content of the presentation or about the specialty in general. And then the second reminder I have is about our future shadowing sessions. So we have these on Mondays and Thursdays weekly, and we'll have them throughout the summer, throughout the rest of this year actually. So if you'd like to stay tuned with more of these shadowing sessions, which we have across different speakers and different specialties, for not only physicians, but also we have sessions for our pre-PA students, we have sessions for our pre-dental students, so pre-health sessions in general. You can either subscribe to our listserv, which is something you can do on our shadowing page, on our website page for shadowing, or really any page. And you'll see the subscription form at the very bottom of one of those pages. So scroll to the very bottom. On the left-hand side, you'll see it and fill it out. You'll be good to go. Or you could just email us. Our email is community@hearts4health.org. We're happy to take any questions there too. But that's all for reminders. Like I said, feel free to email us with any questions about what I mentioned or any of our other programs. We do have a couple other programs around, and we'll actually be releasing applications for those programs later this summer in July or August. So definitely stay tuned for that. Although that's all, so Dr. Kittleson, feel free to take it away.
Great, thank you so much. Can you hear me okay?
Perfect.
Okay, great, wonderful. So I'm here to talk to you today about advanced heart failure and transplant cardiology, the most amazing specialty ever. I'm going to tell you a bit about how I got into it, what it entails, and then we'll talk about some amazing patient stories. So what is advanced heart failure and transplant cardiology? So as the name suggests, I treat patients with heart failure. One of my things I have to do is figure out the diagnosis. There's a lot of underlying causes for patients with heart failure. Is there a cause for which there might be a treatment for which the heart failure may be reversible if I can identify a cause and direct disease-directed therapy? And then sometimes, despite our best efforts at treating heart failure, the disease progresses and then patients need advanced therapies. When we think about advanced therapies, we think of those for patients with more end-stage heart failure, things like heart transplantation, mechanical circulatory support, which I'll explain in more detail, or hospice for those patients who have no more life-prolonging options available to them. So when we think about advanced heart failure, we think about it existing on a continuum. So when someone is diagnosed with heart failure, they initially have a decline in their quality of life, but then with good medical therapy, they often stabilize and can feel well for many years until they hit this gray zone where their quality of life is worsening and their survival is decreased. It's a time when the medications you put them on, the oral therapies, are failing. And that's when it's time, as the physician caring for the patient, to make many major decisions with the patient and their loved ones. Are they a candidate for mechanical circulatory support, MCS, or transplant? Are they eligible for that? Are they interested in those options? And then if they're not eligible or not interested after a shared decision-making discussion, thinking about things like palliative care, defibrillator deactivation, and or hospice. So when we think about patients, when they hit that tipping point, that slippery slope, when they start to get worse, we try to fix the treatable causes if we can find them. Sometimes we can optimize medications, optimize electrical device therapy, and patients can feel better. But oftentimes we can't reverse that downward slide, and we think about these options for our patients. When we think about mechanical circulatory support, it's really a triumph of biomedical engineering to create these pumps that can assist or actually take over the function of the heart. The left ventricular assist device is shown there on the left. The HeartMate 3 is currently the one in use. And it's non-pulsatile flow. So if you try to check the pulse of someone with an LVAD, you won't feel one because it's not pulsatile flow like a beating heart. It's non-pulsatile, continuous flow through a magnetically levitated rotor that spins at thousands of RPMs, sucking the blood out of the left ventricle and into the aorta. It's powered through batteries or an electrical source through a drive line that comes through the skin in the upper abdomen. It's about the width of your finger. So living with an LVAD is a big deal. You have to care for the drive line. You have to make sure you have a power source, but it really is something patients can live with end-stage heart failure until a transplant or as their destination therapy if they're not transplant candidates. The total artificial heart's shown here in the figure on the right, and that essentially takes over the entire functioning of the heart. The old heart is removed. This is placed. It has two chambers, with one for the left ventricle, one for the right ventricle, and will be placed in people who've got biventricular failure, right heart and left heart are both failing, or other conditions for which an LVAD alone wouldn't cut it. And it also has drive lines that come through the skin. So this is the science behind these devices, but I think a picture is worth 1,000 words. And these are pictures from the promotional materials on the websites of real patients living with these devices. We have a woman living with an LVAD on the left, and you can see that harness, the black harness she's wearing are her battery packs to power the device while she rides the bike. And then the picture on the right is from a gentleman with a total artificial heart. And you can see that little suitcase, gray suitcase device by his feet is what's powering the device. It has a much larger motor because it's a bigger device. And he's playing basketball. So really, this is a miracle. It's a gift of life to keep patients alive. But really, the ultimate therapy, the best therapy for advanced heart failure is heart transplantation. And it really is a story of the miracle of science. So what do these three pictures have anything to do with heart transplantation? Well, if you think about it, there are so many scientific advances that have to come together all at the same time to make a heart transplant work. You have to have surgically, you have to be able to sew things together. You have to have good post-operative care. The patient survives this major operation. You have to have them live for a certain period of time without a heart at all while you're taking one out and putting one in. And you have to have anti-rejection medicines that work so that patients can survive without rejecting their donor heart. So what does this first picture have to do, these women doing embroidery, have to do with transplant? Well, it turns out that one of the major surgical barriers to transplantation initially was the ability to sew blood vessels together because they were so very delicate. And it was Alexis Carrel, a French surgeon, inspired by his mother's embroidery circle and the fine embroidery needles they would use and the fine lace embroidery thread that he adapted to suture blood vessels together, for which he actually won the Nobel Prize in the early 1900s. So that was one barrier down. Immunosuppression was another major problem. How do you keep the body from rejecting the heart without ramping down the immune system to such an extent that patients die of infection? So this push and pull between rejection and infection. Well, this figure here in the middle is a fungus called Talipocladium inflatum. And it turned out that there was a drug company in the 1970s that told their employees when they went on vacation to take plastic bags with them and get soil samples. They were trying to discover new compounds that might turn into drugs they could use. And in Wisconsin and Norway, this fungus was isolated. It turned out it had cyclosporin in it. Novartis, the drug company at the time, was looking for antibiotics. It was a terrible antibiotic, but it was a great immunosuppression agent. And that's really where the science of transplantation came through. And this picture here is of Groote Hospital in Cape Town, South Africa, with Table Mountain in the background, so called because it has a really flat top. And that was the very first heart transplant was performed in 1967, but it really took so many building blocks to make it work. And cyclosporin wasn't established until the 1980s, and that's really when transplantation took off. So where are we today? Well, if we look where we are now, first thing I want you to pay attention to on this graph is that over 100,000 heart transplants have been done internationally over the last 2.5 decades. The second most important point is look at the survival, which has increased in successive eras due to better techniques of patient selection, donor selection, taking care of the donor, taking care of the recipient, the intraoperative course, the anti-rejection medications. So median survival in the current era is about 12.5 years, which is certainly better than anyone can expect with end-stage heart failure, where survival is measured really in days, weeks, or months. So why did I pick this amazing specialty? How did I become an advanced heart failure transplant cardiologist? AHFTC is our abbreviation. Well, as you all know, it takes 4 years of college, 4 years of med school, 3 years of internal medicine, 3 years of cardiology, 1 year of advanced heart failure transplant fellowship, and finally a real job. So I'm going to give you a sense of why I went on this path. What were the things that inspired me along the way? So why did I go to medical school? Well, my parents told me to. I'm the 5th generation of doctors in my family. I'm the daughter of Indian immigrants, and it was pretty much set in stone that I would do whatever my parents told me, and they told me to go to medical school. I was very blessed, though, because from the very first day of medical school, I was entranced by all the incredible science I was learning, how the body works. And I settled ultimately on internal medicine residency for 2 reasons. Number one, I felt it was the most efficient use of all the knowledge I'd gleaned in medical school. I spent so long memorizing everything, and almost everything seemed to apply to internal medicine, so it made sense practically. And also, I had the most extraordinary mentors. One in particular who taught me, don't memorize, reason things out. If you understand pathophysiology, you will understand etaology and differential diagnosis. And his words have stayed with me for decades now on how to reason through medicine. I wasn't set on cardiology forever. I got inspired in the middle of residency to do cardiology. And there were many reasons. One, I fell in love with the pathophysiology. I think the pathophysiology of the heart is very easy to understand. I enjoyed that. I love the fact that the history and physical exam truly matter when you're caring for a patient with heart disease. You can't diagnose unstable angina without a history. You can't diagnose heart failure without a physical exam. I like the fact that I'm not relegated to looking at blood tests or imaging tests. I have to look at the patient to figure out what to do. I love the strong evidence base for so much. When I give a patient a pill, generally, there's thousands of patients worth of randomized controlled trial data to tell me that what I'm doing is the best thing for my patient. How patients die, what do I mean by that? I think medical school residency takes a real emotional toll on us for many reasons. That's the uncertainty of not knowing things, having to learn things, feeling inexperienced, but it's also watching patients do poorly and die. And for me, watching patients die of cancer was one of the hardest things I ever did. Something in me emotionally couldn't wrap my head around it. Was people dying of cardiac problems, while still tragic, somehow made more sense to me that I could process emotionally. And that's one of the reasons, additionally, I chose cardiology. And finally, that you sense a theme here, it comes down to mentors. I had the most extraordinary mentors in the field of cardiology, people I wanted to be like when I grew up, who inspired me. And then when I picked cardiology, why advanced heart failure transplant? Well, the field of heart transplantation is full of human drama. I see a miracle every day. I see the greatest triumphs. I see terrible tragedies, but I'm able to make a difference in people's lives. And I love that. I love the fact that I get to do a little bit of everything. I do outpatient clinic where I've known patients for years. I do inpatient service, including the intensive care units where I have to make split-second decisions to try to save someone's life. I get to do procedures like angiograms or heart biopsies. I get to do things like read echocardiograms for little imaging variety. And I love the fact that I can use my medical knowledge in so many different ways. No 2 days are the same, and that's exciting. So what does a week look like? What do I do all day as an advanced heart failure transplant cardiologist? And I say there are many different models. You will see many different models. Now, I am at an academic medical center. I don't have protected or funded research time. I essentially do clinical medicine. I'm a clinician. So I'll spend my early mornings in meetings. If I'm on the inpatient service, the mornings will rounding with the team, the medical students, the residents, the fellows, giving weekly chalk talks on important topics they need to know about. Outpatient, I'll be in clinics, heart transplant clinic, heart failure clinic, general cardiology clinic, doing procedures. Lunch is usually meetings. Afternoon, maybe more clinics. The evening is family time. Family time is very, very important. I work hard when I'm working hard, and I try to carve out time for my family when they need me. But once the children are hermetically sealed in their sleeping chambers, not to be heard from again until morning time, it will be time for some research and administrative work. So what is it about this schedule? What's with all the meetings I go to? Well, I love taking care of patients. Patients is my number one passion. But what you may discover, as I did, is when you're in medicine for many, many years and it starts to get routine because you're experienced and that feels great, you want other things to challenge or excite you. And that may be turning to national opportunities to be involved in writing the guidelines that clinicians use to guide their care, or educational activities, or even within your institution. I'm on a bioethics committee. I'm on a peer review committee where we review cases for potential errors or things that could be done better. The fellowship, I run our transplant fellowship. So lots of different opportunities. And then I told you I didn't have any funded research time. So what's with all this research administrative stuff I do? Well, there's a lot of different ways to do research instead of being a typical NIH grant funded researcher. You can always get involved with projects with fellows or residents or other institutions. I also have a passion for medical narratives and writing. So I think our priority as clinicians should always be outstanding patient care. But you may find as your career moves on that it's not your only focus when you feel you've achieved a mastery of patient care. And so now I'm going to move on to some cases. I want to tell you some stories. And none of these stories are very heavy on the science. These stories are actually very heavy on what I learned how to be a better doctor. So I'm going to give you some lessons learned by telling stories about patients. All of these patients have given permission in that I've published these essays in various medical journals. You'll see the references listed as I go on. So the theme of all of these is that good judgment comes from experience, but experience sometimes comes from bad judgment. So don't just learn from your own mistakes, you can learn from mine. So I'm going to tell you a story about my first terrible diagnosis. So I remember being in medical school and really loving learning new facts. I loved collecting interesting facts, like knowing that dopamine receptors, where dopamine deficiency caused Parkinsonism. So if you couldn't give haloperidol, a dopamine antagonist, to someone with Parkinsonism if they were delirious. Little facts like that, I collected them. I loved knowing the answer. I loved being right. And then one day, a woman came into urgent care when I was a medical student, and her daughter had brought her in because her mother had told her, "Oh, I feel a lump in my breast, and that's kind of weird." Her daughter put her in the car and brought her straight to urgent care. And at urgent care, the minute I pulled down her gown to examine her, I knew exactly what it was. It was an inflammatory breast cancer. I could tell simply by the redness and dimpling of the skin over the surface of the mass, called peau d'orange. And it was the first time I'd realized that sometimes knowing the right answer is a terrible feeling, because knowing something, that enjoyment of being right, sometimes means something horrible for the patient. So I wrote in the essay, I'd always relished getting the right answer instead of thinking about the patient behind the answer. And this case, my first terrible diagnosis, allowed me to see both sides of the diagnosis. And what I did, which I feel badly about now, even decades later, is my attending physician and I told her, well, it could be an infection. It could be something else. We're going to set you up for this test and this specialist appointment. We didn't name the elephant in the room. We didn't say cancer. And I feel we did her a disservice by not giving her a full spectrum of her potential diagnosis. So now when I make an awful discovery, I do offer patients an honest differential diagnosis. I go through the best and worst case scenarios, but it's guaranteed, even if I don't say it, they're thinking it, and it's better to name the elephant in the room, to give it a voice, to give it a plan. And I always acknowledge to patients when I give them a terrible diagnosis that we both may have more questions than answers, but I promise we'll make a plan to get the answers. So that's a lesson I learned from an experience where I didn't think I did as good as I could in medical school. This is another piece I wrote called 142 Days that appeared in JAMA Cardiology. So as I mentioned, I'm a heart transplant cardiologist, so I often care for patients who are waiting in the hospital for months, waiting for a transplant. And they're living in this crazy limbo where they can't leave the hospital, they're too sick. And the only hope they have of ever leaving the hospital is an enormous surgery that could kill them, and they don't know when it's going to happen. They could wait another day, they could wait another month. That's what every single day feels like. And I had one patient in particular who waited in the hospital for 142 days for a heart and liver transplant. And after he had a happy ending, he got his transplant, he went home, he did well. I reached out to him, and I reached out to the fellow, my cardiology fellow in training, who took care of the patient with me. And I said to my fellow, and I said to my patient, I don't know what it felt like from your perspective. I only know what it felt like from my perspective. Let's all write 500 words about what it felt like, and we'll put it together in an essay. And this was the essay. So the fellow said, his safe passage to transplant was my responsibility. I think he sensed this and eased my anxiety during afternoon chat. So the fellow was so worried that the patient wouldn't make it. And even though that success was out of his control, the patient sensed that and tried to comfort the fellow. Me, as the attending physician, said, as I walked out of his room, I would give myself a mental shake, considering how to provide the right balance and tempered optimism and managed expectations to the patient next door and the 15 other patients after that. To me, the feeling of compartmentalization you have to employ as a physician sometimes feels so foreign and so strange. You go into one patient's room and you're celebrating, and you go into the next patient's room and you're mourning. It's such an odd balance of how you spend your days. And the patient said, I was constantly reading facial expressions, looking for reasons to worry, but the physicians all had the same game faces. Their optimism and confidence, however unrealistic, were a constant anchor. So what I found really extraordinary, what I discovered in writing this piece with my fellow and my patient, was we all were scared, and we were all trying to comfort each other. And in a way, that shared uncertainty and an effort to comfort each other comforted us all. And I thought that was a really interesting lesson to learn, that we are in this experience together, both our fear and our comfort. This is a piece I wrote about called The Privilege of Grief, because one thing that's so difficult as a physician is dealing with the bad outcomes. And you may have heard about the stages of grief that loved ones go through. Elizabeth Kubler-Ross wrote a book on the stages of grief: denial, anger, bargaining, grief, acceptance. But it's different, isn't it, for a physician? I don't think we have the same luxury to mourn the way a loved one does. So how do we process bad outcomes? And I fashioned, through hard-won experience, 3 steps in the trajectory of a doctor's grief. What do you want to do? You want to first, if something bad happens to a patient, figure out if it was fault or fluke. The next step is to distinguish whether it was expected or unexpected, unforeseen from the expected. And ultimately, you have to accept on some level that control is an illusion. So let's talk some more about that. So when you separate fault from fluke, separating fault from fluke means If you made a mistake, you need to process it. You need to talk to trusted mentors or colleagues. You need to figure out how you will never do that again. If it was a fluke, on the other hand, if the bad outcome was completely out of your control, you can't change your practice based on it. You can't doctor by anecdote, or you may end up giving substandard care to future patients because of your fear rather than of science. Distinguishing the unforeseen from the expected is important because what happens with experience is you get better and better at predicting when something bad is going to happen. And your responsibility is not only to attempt to prevent it, but to prepare the patient and their family. So if something horrible happens and neither the patient nor the family were expecting it because you didn't prepare them and you should have known, that's on you to do better. And finally, if it truly was a fluke, not your fault, and if you did everything you could to prepare the family, at some point you just have to let it go. You have to accept, that old joke, what's the difference between God and a doctor? God knows he's not a doctor. You have to realize that not everything is in your control. So thinking some more about that, thinking about how we make predictions. Every time we take care of a patient, we're making a prediction. We're trying to figure out, are they going to do well or are they going to do badly? And I wrote this piece contrasting the outcomes of two patients, Mr. R and Miss S. They were both listed for transplant. Mr. R was pretty healthy, actually. He was still an outpatient, and he had a terrible post-transplant course. He was on ECMO, extracorporeal membrane oxygenation, because of heart failure right after the transplant. He needed a tracheostomy. He had pancreatitis. He had heparin-induced thrombocytopenia, which led to toe amputations. 10 years later, he suffered from terrible migraines, coronary vasospasm, giving him chest discomfort. He was on dialysis because of kidney failure. And I asked him, do you have any regrets? And he said, no, I'm glad I went through transplant because I'm alive and I've seen my son graduate from college, and it's really what's my goal. Miss S, on the other hand, was very, very sick at the time of transplant listing. She was an inpatient. She was dependent on inotropic support and cardiogenic shock. She could not leave the hospital without a transplant alive. Her post-transplant course was also horrible. She had multiple strokes. She couldn't talk. She couldn't move half of her body. A year later, she could talk a little, walk with a cane, but she absolutely regretted the transplant. She wished she had never done it. So you have two scenarios of bad outcomes. Both Mr. R and Miss S had bad outcomes. But Mr. R was at peace and happy, but Miss S wasn't. Does that mean that we made the right decision in Mr. R and the wrong decision in Miss S? Actually, no, because if you really dive deep, you'd say, maybe Mr. R never needed the transplant in the first place. Was he really sick enough? He was outpatient. He was working. Maybe he didn't need to be on the transplant list. Whereas Miss S, you know what? Even though her outcome was bad, she would have died without a transplant. So when you're making predictions, you have to remember to judge yourself by your medical decision-making, not by the outcome. So the way I think about it is medical decision-making is an enormous responsibility when we get it wrong, and even when we get it right. And as a person, we absorb the grief, anger, and frustration as a tragedy, but as a physician, we have to focus on the questionable decisions, not the bad outcomes. And moving on to another patient who I learned a lot from, this is a piece I published again a few years ago when I cared for a patient who was awaiting heart transplant, and he spent a few months in the hospital, and I never spoke to him. The first time I spoke to him was when he came to the outpatient clinic for his first post-transplant visit. And the reason I never spoke to him is because he was deaf, and finding an ASL, American Sign Language, translator for an inpatient takes a lot of time. So instead of speaking to him directly, I would translate through his father instead of an independent translator, and send my fellow back later to explain more things to him with an interpreter. And really, that was the wrong thing. Did I do things right medically? Absolutely. I saved his life. I got him to transplant. I did all that beautifully. But I didn't offer him the communication he deserved. So what I learned from this case is that I fell into a complacency born of pragmatism and confidence in my abilities. I knew I was providing the best medical care, so I ignored the importance of direct communication. And it made me realize that diseases may become routine with experience, but patients must not. So to treat every patient as unique, regardless of their disease. And, I've told you a number of stories now, patient scenarios I've been through, mistakes I have made, things I'm trying to do better. And the elephant in the room really is COVID, because COVID really tested the physician-patient bond, the fear of COVID, the mistrust of COVID, the mistrust in medical science that happened through COVID. So let me tell you some of my experiences caring for patients through COVID. This is another piece I published in the New England Journal. It was about a patient that came to see me because he had chest pain and he had an abnormal stress test. And the first time he saw me, I said to him, well, based on the data, based on the randomized trials, based on the evidence and the guidelines, you don't need an angiogram. You need to take medications that will reduce your risk of heart attack, relieve your chest discomfort, and then let's circle back and see how you're doing. He was not having that. He was a little suspicious. He agreed with me, fine, I'll take your meds, but let's put an angiogram on the books in a few weeks. I said, okay. When he was supposed to follow up with me a few weeks later, the whole world had been turned on its head. To me, the big day was March 13th, 2020. That's the day my kids' school closed down indefinitely. We didn't know when they were going to go back to school. The whole world had shut down. Lockdown was in place. We weren't seeing patients in the office. And a week later, it was time for him to see me again. But now we did it over the phone. My very first phone visits, very first experiences with telehealth. And it was amazing to me that a week or two prior, he'd been dead set on wanting that angiogram, even though I told him medically I wasn't sure he needed it. Now he said, you know what? I don't want to go to the hospital. I want to go to near the hospital. I don't want to get COVID. I'm not having that angiogram. And it was striking to me how much fear of COVID was greater than his fear of a heart attack. And I thought, wow, we're going to see some very different things through COVID, how fear is going to impact medical decision-making. So overwhelmed by the anticipated harms of COVID, we must remember that other diseases will continue to progress during the pandemic. With all our patients, we have to ask ourselves, what's the best approach to treating their disease? And how does our fear of COVID affect our shared risk-benefit calculus? And embrace new ways of communicating, listen not only to patients' symptoms, but also their fears. Because other diseases will not take a hiatus as the pandemic spreads exponentially around us. So that was my very first foray into understanding how the pandemic was going to change our care. I wrote another piece that occurred right about when there was a presidential news conference talking about the wonders of hydroxychloroquine in treating COVID-19 or preventing COVID-19 or whatever it happened to be. And I had a patient I'd followed for years. He'd been a wonderful patient of mine with stable coronary disease, and we got along beautifully. And he gave me a call right after this presidential press conference and said, I'd like a supply of hydroxychloroquine to have on hand. And I said, no, there's no data for that. It's one, it could be dangerous and interact with other things. Two, you could be taking it away from patients who actually need it for their rheumatologic conditions. And three, there is no data to say it's beneficial for you. And he got very angry with me. And I was shocked initially by his anger. But I realized that I had science on my side, but he had the fear of death on his. And we could disagree on the best way to remain safe in the pandemic, but in the end, still trust each other. And I realized through this patient, as we talked through his anger and we went into the uncomfortable emotions and heard each other's side, and he could see that I heard his pain, I felt his fear, that the fear and uncertainty of COVID might have strained our physician-patient bond, but it did not break it. And that this applies through everything, not just COVID, that patients need to know that we will not abandon them if we disagree, and our trust will be stronger for it. And that's a big rule of mine when I'm caring for a patient who doesn't agree with my plan. They're not buying what I'm selling. You can tell, even if a patient doesn't tell you forthrightly, if they're not buying what they're selling, just their body language will tell you. And I like to call out the elephant in the room. I see you don't trust what I'm saying. Tell me how I can explain it better, what doesn't make sense. And if we reach an impasse where we simply have to agree to disagree, I will always offer a second opinion, help to facilitate a second opinion, because ultimately the patient needs to feel trust in their care. And if the second opinion is a win-win, because if the second opinion agrees with me, I'm vindicated, I look great. And if the second opinion doesn't, then maybe I'll learn something new. So the patient benefits, I benefit. Always try to reach consensus however you can. And then a final COVID piece I put together was about one of my heart transplant recipients, again, someone I'd known for decades, who refused to get vaccinated. And she was very concerned about it changing her DNA, about a chip that was going to be monitoring her in the vaccine. And I had led her through transplant. I'd led her through rejection. She trusted me implicitly, but she would not trust me on this. And it was striking to me how we had a pandemic of COVID and a pandemic of mistrust. And I was shocked that patients have died. And my own patient, she ended up passing away from COVID, not for the lack of life-saving interventions, but for our lack of trust in them. And now I treat every conversation with a vaccine-resistant patient as if it might be our last. I explain how I apply the same standards to my patients as I do to my own family, and hope I can reach them before it's too late. And I think our goal is to rebuild this trust in medicine, one patient at a time. And I think we have in many ways, and these are lessons we can learn from COVID, because there will be other stresses in the future that challenge the patient-physician bond. And then finally, I think you have to learn how to cherish your victories. Medicine is hard, but that doesn't mean there aren't wonderful things to bask in the things you do right, to keep a sunshine folder for your dark days. And this is a poem I wrote about that, a lesson I learned. I keep the kind notes from grateful patients in my second desk drawer. For mistakes, I keep a mental file that replays on nights I can't sleep. The near misses, the misdiagnoses, the wrong decisions live there. Anxious, overweight dyspneic, I almost didn't order the CT. Mitral valve prolapse, fatigue, and night sweats, I missed endocarditis. Cardiac sarcoid, steroids, or transplant, I chose wrong and she soon crashed. The stash of kind notes never sees the light, but the mental file stays fresh. Happy endings, all alike, but every mistake cuts in its own way. And I hope this isn't the case for you. I hope that as you progress, you will remember and cherish your victories, because they are as important as the lessons you'll learn from your mistakes. And then finally, I'm going to close out with some life lessons. I'm on Twitter. I post often some wisdom I've gleaned from my own mistakes and my mentors. And sometimes I'm asked, and this is one of my tweets, how I do it all with 3 kids and a career. And I don't, because career extras get put on hold when the family requires more attention. Life happens in stages. You're not supposed to accomplish it all at once. And here's a graph I like to show to illustrate that point. This is a plot of my PubMed citations, publications by year. And the red line is when I am first or senior author. Okay, so what do we see? Fellowship, doing a pretty good job, publishing some stuff, early career, a nice steady rise, and some drop-off points where my productivity tends to flag. Why would it flag? Well, kid 1, kid 2, kid 3, but I recovered and did better. So that's the first lesson. It's okay to take breaks. When I had my kids, I felt that all I really could do was keep my patients alive and keep my kids alive. I could not do anything else. I said no to everything else, and that's okay to know your own priorities. Second thing is, it's okay not to love research. Look at this span between 2012 and 2018. There wasn't a single first or senior author publication by me. I had some other publications because I collaborated with people, but I initiated nothing. That's okay too. There are other ways to make an impact in medicine. It doesn't have to be research. And it's more than okay to cultivate other passions, and that's those green lines you see here. And that's the medical narratives, essays, and poems that I developed a passion for as my career progressed. I thought when I was a medical student, resident, fellow, that once you have a real job, you'd have that same job until you retire. I didn't realize the many ways one could reinvent oneself, discover new passions, new interests within medicine. And the possibilities are limitless. So that's really everything I wanted to say to you. While self-promotion makes me a little nervous, my editor has made me promise to include this as the last slide of every presentation I give. It is a book I've recently written called Mastering the Art of Patient Care. It's based on my mistakes and the wisdom of my mentor so that you don't have to make all the mistakes yourself. It's available from Springer. It's usually out of stock on Amazon, but it is available at Springer and may be free depending on whatever institutional subscription your center has. But I think you might find the tips, tricks, and pearls helpful. Well, thanks so much for everyone's attention. And now I will close out and be happy to take any questions for the rest of the hour.
Absolutely. Well, first of all, thank you, Dr. Kittleson, for getting this all together. I really, really do admire the narrative medicine perspective that you take on these cases. It's something that we have not seen, and we've had over 70 sessions now. So very, very refreshing to see that sort of perspective. So to begin our questions, the first one is about your PhD. You talked about going through medical school, residency, fellowship, and then another fellowship past that. But in terms of your interest for specifically pursuing a PhD,
yes.
What was that?
Yeah, great question. So the traditional way to get a PhD is during medical school, the MD, PhD, MSTP program. I did not do that. I always knew I wasn't a researcher. I just wanted to take care of patients. However, when I got to my cardiology fellowship, there was an opportunity to get a PhD in what was called clinical investigation, essentially biostatistics and epidemiology. So clinical research, not a basic research PhD, a clinical research PhD. And there was an opportunity to do it simultaneously with my cardiology fellowship. I wouldn't take any extra time. My fellowship at the time was a 4-year structured fellowship with 2 clinical years and 2 research years. And it turned out I could fashion it to do a clinical year, a research year that was all classes at the School of Public Health, a second research year where I would write up the papers, defend my dissertation, or finish up the research, and then a 4th clinical year where I would finish things up. So for me, the PhD was a great opportunity because I was much more interested. If I was interested in research at all, it was going to be clinical. Second, it wouldn't take any extra time because I could do it simultaneously with a cardiology fellowship. And the third reason I did it is I had a wonderful mentor in residency, actually. And when I went to him and I said, I want to be just like you. I want to be an amazing clinician. And he said, you know what? You still have to give research a try because otherwise you'll always regret. You can't go backwards in life. While you're in training is when to immerse yourself in it. You can never do it later. And you may change your mind, you may not, but you got to do it now. So I took his advice to heart. And when I had this opportunity in fellowship to dive really deep into research, I figured this is my opportunity. Do I not like research because I don't like it, or do I not like it because I'm not good at it? This will be my way to figure that out. And through the PhD, I pretty much discovered I still don't really love research. I don't love doing it myself. And so those are the reasons why I did it, to really give it every extra bit of chance to incorporate as part of my life so I could be at peace that it truly wasn't what I was interested in.
And speaking of research, like you've talked about thoroughly, you've done quite a lot over the past years as an attending, in training. For the undergrad students out there who might be early on in their career, could be a freshman, a sophomore, or even towards the later years nearing their application cycle, what would you recommend that they do to get on the side of clinical research in specific?
Yeah, it's a wonderful question. And I'll tell you, I know this through my own experience, that when it comes to picking a research project, you should pick the mentor, not the project. I talk about this in my book, actually. You know, it's really, when you are really early in your career, you don't really have a research focus. You're not supposed to have a research focus. You just want to learn how do the mechanics of research work. So you pick someone with a proven track record of mentoring other trainees and productivity, because there's 2 things you want to get out of that experience as an early trainee. You want to get a tangible output that you can show on your application to show what you did. And you want to get a sense of what it feels like to do the research. How do you figure out who that mentor is going to be? Well, sometimes it's helpful to know other people more senior than you who happen to work with that person, and now they've gone on and graduated. What was their experience like? So get the insight of people who've worked in research who are a year or 2 ahead of you in their training to get a sense of how their experiences were. Second, do a PubMed search for them. They publish 3 articles a year. you're probably not going to have the experience you want. If they publish 10 plus articles a year, wow, this is someone who's got a good machinery in place and are trainees on their publications. That's going to give you a good sense of what kind of an experience are you going to have as a trainee working with them.
And then another question about research. You mentioned later on, as an attending, you started to get interested in narrative medicine, had a few publications there. What drew you to narrative medicine? What was the impetus there?
Yeah. So, growing up as the fifth generation of physicians in my family and an only child, I did at one point tell my parents I wanted to be a writer. And they said, that is not a marketable skill. Go to medical school. Fortunately, I love medical school and it was the most wonderful thing I could have done. But I think passions don't leave you. They may take a hiatus for a while. So when I was in the throes of just trying to master medicine, medical facts, and that's really what you do during medical school and residency and fellowship. You're just trying to master the skills needed to care for a patient. All my energy was in that direction. I would read medical narratives. They appear in JAMA, the New England Journal, Annals of Internal Medicine. There's so many outputs to read, really interesting, and I loved them. But then all my energy was consumed. Then it was having kids, and all my energy was consumed to keeping the kids alive and, getting my work done. And then my brain kind of woke up and I'm like, wow, it's interesting to me. And I'm sure everyone who does narrative medicine has a different journey. But for me, I began to see my patients in a different light where I wasn't so consumed with just trying to understand the best science to give them the best care. That to me felt more straightforward and just knee-jerk reflex because I knew how to do the medicine. I was an expert in the medicine. I could take a step back and think about their emotional journey and what do I learn from that? And that's what inspired me to write the narrative medicine pieces.
And at the end, you mentioned your book. What was the experience like of writing an entire book, especially as a physician? We know there's a couple of physician authors out there, but it's not really typical that a physician will go out of their way to dedicate a good chunk of their time, I'm sure, to writing an entire book like you did.
Yeah, it's funny. I never had a plan to write a book, honestly. It sort of came from Twitter, which is a weird thing to say, but I joined Twitter in 2018 because one of my fellows inspired me. Because I had this thing on rounds that I would always do where a trainee would say something and I'd say, Kittleson rule number 1. Never give something IV if the patient can tolerate PO. Just make up these little rules. And they'd go around and one of my trainees actually wrote them all down at the end of his fellowship and handed me a printout of all my rules. I'm like, oh yeah, I do say all those things. And then finally in 2018, this fellow said to me, you got to put these on Twitter. There's a whole medical education community on Twitter. People would love these. And I said, I don't know, social media, it's so scary. I don't know about that. It finally helped me set up a Twitter account. I didn't know how. And then I started like posting these little things and I hashtagged them Kittleson rules because that's what I would call them on rounds, Kittleson rule number 1. And so that's where it started. And there was a real hunger for them, actually. To an experienced clinician, everything I would write would be, duh, of course we know that. That's totally obvious. But as someone in training, it's not totally obvious because you haven't had the experience. And so people would reach out to me and say, when are you going to put these in a book? And I said, wow, I don't want to just publish a book that's random sayings all over the page. That's weird. So what I did, because I'm a very organized person, this was back in late 2019, early 2020, I think. I took a list of like 150 of them and I put them on a spreadsheet. And then I put them into categories. I'm like, well, this one's more about education. This one's more about being a new attending. And this one's more about how do you make a diagnosis. And this one's about how do you call a consult. And then I sorted them by what category they were in. And I used that to inspire an outline. And I made a very, very organized outline. If you ever look at the table of contents of my book, you'll see it's basically the outline I wrote it from. And then every morning, because I wake up at 4:30 in the morning, I'm an early riser, every morning for like 20 to 40 minutes, depending on how much energy I had, how many calls I'd received the night before, what service I was on, I would just write. I'd say, I'm at this part of the outline. This is what I'm going to write about. And it was just my experience of what got me through medical school. How do you pick a research project? How do you pick a training program? What do you do if a patient doesn't agree with you? Why do you give bad news to a patient? What's it like being a woman in medicine? It's just life experience that inspired by my patients. And then, because again, one of my dear colleagues on Twitter introduced me to his editor at Springer, which is a medical textbook publishing company, they were delighted to be given a full book already done to publish, and the rest is history. So I think it really, my goal was not to write a book, and my goal was never to be an author, but because I have things to say that I truly think will help the next generation of physicians overcome a lot of the uncertainty and fear of inexperience. It is very scary to not have experience, and you will get it. Everyone does, but it can happen easily or it can happen difficultly. And I'd rather help people do it more easily.
Wow, what a story to the behind the book.
Yeah.
You mentioned the next generation of providers. So to tag along with that question on kind of like a similar line of thought, where do you see your subspecialty going in the future? I know that there's quite a few subspecialties, and we've seen them on shadowing that have emerged recently, and past that, the ones that we already have, they're continuing to develop. Where do you see yours going?
You know, advanced heart failure, transplant cardiology, there's so much exciting things going on in the field. First, let's get better at treating heart failure so fewer patients need a transplant. And there are so many incredible medical advances in the best medications to give patients to help them feel better, live longer, stay out of the hospital, potentially improve heart function. We're at the point now we have all these amazing medicines, and the next step is better implementation. So implementation science is going to be a huge part of heart failure management. What about mechanical circulatory support? These devices you can put in someone to keep them alive forever or until a transplant's available. But there's downsides to them, right? They've got drive lines that come through the skin. You need to plug into an outlet or have a battery pack with a 4 to 6 hour life. It's not the greatest way to live. What if they were fully internalized? What if you could charge them through the skin? So there's so many more advances that can happen with those pumps. What about transplantation? The rate limiting step in organ transplantation is donor supply. Patients die on the waiting list every day because donors are not available. You can't pluck them off a shelf. You have to wait for a tragic outcome, a donor who will not make it, brain dead or close to brain dead, and then with the agreement of the family and the medical screening process, harvest the organs. What if there were a better way? What if there were a way to grow organs in a 3D printer? What if there was a way to do xenotransplantation, where you take a gene-edited pig heart, done last year at the University of Maryland, though the recipient did not survive very long, but a good proof of principle. There are so many options out there. So I think our field is here to stay. I don't think people will ever stop getting heart failure, but I think we can make them better, hopefully need fewer transplants, have better devices to make them survive to transplant. And we might have a time when a transplant isn't something where you need a waiting list for, but something you go in as an elective procedure because they're just waiting for you on the shelf.
Wow, that is quite the future to look forward to.
Yes.
We talked earlier about your PhD. Did you consider any other types of degrees like an MPH or MBA?
Yeah, so the part of my fellowship in cardiology, you had the opportunity to get an MPH or a PhD. And I was like, wait a minute. In 4 years, you're telling me I can get a PhD? Why get an MPH? I mean, biostats and epi are part of the MPH too. I'll just go for the PhD. So that's why. MBA, nope, I never considered. Don't understand economics. I'm absolutely, like most doctors out there, I'm sadly deficient in anything related to macroeconomics, microeconomics, business, organization, structure, finances. So that was never an interest of mine.
And maybe just a couple last questions to round out the hour. Going back to medical school, for especially the people going through the application cycle right now this summer, they're probably at least already done with or working through school lists by now. I know it's been a while since medical school, but what would you have to say about choosing your medical school? What were values that you put at the top of your list, or how did you consider those values, just for people to kind of glean?
Absolutely. Absolutely. Now, I have to tell you, it's interesting you ask that question, because my oldest son, who's 11, is going to be going through the application process to get into high school soon, or secondary schools, which is not unlike the application process here in Los Angeles to get into medical school. And I'll tell you my philosophy, which is the same for him as the age 11 as it would be for medical school applicants. And here's my philosophy. This whole idea of this medical school is better than that medical school irritates me to no end. I really think how you should decide where you apply is number one, at whatever school you're at, what does the counselor tell you? How many schools do you need to apply to, right? What's the X number? Because you really want to get into medical school based on whatever your qualifications are. This is the X number you need to apply to. The second thing you have to ask yourself is, where do I want to live? Is there personal geographic preferences that are guiding my decision? And after that, you make your list of X number of programs, meeting your guidance counselor's recommendations of what you need, of what kind of a mix you need, practically, and based on your personal, I cannot go to program X in city Y, well then don't put it on your list. And you're left with, X number of programs, any of which you'd be happy to go at. And then you leave it up to the fates that be. I think getting to medical school has become such a highly competitive process that really it's not a question of where you go, it's that you go. And remember, every single medical school uses the same textbooks. I mean, it's really not the place, it's you having your system to get all that knowledge into your brain. And if they have problem-based learning or not problem-based learning or case-based this or early clinical that, honestly, you just got to get the knowledge into your brain. Ultimately, it'll be your aptitude, your initiative, your discipline, motivation, organization that's going to make this happen no matter where you are. And there is, in chapter 1, I talk about sort of my strategies that got me through medical school, but honestly, it doesn't matter where you go. So that's my take on it. When it comes to residencies, I think it's a little bit different because you have to factor in things like the volume and case mix, the autonomy, how comfortable do you feel with your culture of autonomy at that place? And you'll get a flavor of the institution, but it almost still boils down to the same thing. There are sick people everywhere. And your greatest teachers will be your patients and the directed reading that you do based on every patient you see, because you're the first 2 years of the textbook learning, you're basically just adrift in a sea out of context. When you finally have the patients as your context is when you'll truly learn. So my best advice is apply widely based on what your counselor tells you to do. Don't put any school on that list you really, really don't want to go to, and be at peace that wherever you end up going, you will be a doctor, and you will be a great doctor because you will work hard at it.
Great advice. One more question just to wrap up this session, and that's going to be about subspecialties. So we know there's heart failure and transplantation, like you had past your cardiology fellowship. What other trainings could you go for after a cardiology fellowship?
Yeah, so there's a lot of them actually. You can go into interventional structural cardiology where you're putting in stents and transcatheter valves. You can go into electrophysiology, which is more pacemakers, arrhythmia stuff, ablations, defibrillators. You can do adult congenital cardiology where you take care of those patients who are now living so long, born with congenital heart disease that they're adults because care is so good. There's imaging where you focus mainly on echocardiography, nuclear, CT, etc. Am I forgetting one? I'm always forgetting one. But you can also be a general cardiologist. And I do half general cardiology in addition to my half transplant practice. And I love that because I think all of us must have a strong foundation in internal medicine and general cardiology because every patient does not come to you with a diagnosis. Sometimes they come to you with a symptom, and you need to have a broad understanding of potential differential diagnoses to guide the patient appropriately. So whatever subspecialty you end up doing, don't forget that every bit of knowledge you've gotten up to that point builds a foundation of experience that helps you care for every patient.
100%. I think that's great advice to end off today's session. I do have some last reminders for those listening in to our shadowers. If you'd like to earn credit for your attendance today, we have a quiz, and that quiz is right now on our chat box. It's on our virtual shouting page, and it's also in our description. That quiz is just a quick 10 questions on a Google form, and we'll have that due on Sunday, June 25th, 11:59 p.m. Central Standard Time. Once you do pass that quiz with at least 6 out of 10 of those correct, we will send over your certificate, and that's going to be automatically sent. So you'll receive that in your inbox, the email address that you list. So be sure to look out for that. If you don't receive it in your inbox, though, please do check your spam folder. And if it doesn't happen to be there, feel free to shoot us an email. We're happy to help track that down for you. But next shouting session will be with Dr. Malhotra. He is the Fellowship Program Director of Sleep Medicine at Washington University in St. Louis, and he was a previous president for the Academy of Sleep Medicine in 2021 to 2022. So we'll be joining him on Thursday, June 22nd. So this Thursday, regular time, 7 p.m. Central. Definitely looking forward to that one. Another specialty I don't think we've seen yet. So we have quite a few this week that we'll be seeing for the first time. And then lastly, if you'd like to follow us for more, we have our Instagram page where we post these flyers, including Dr. Kittleson's, Dr. Malhotra's, and more. We also have our listserv, like I mentioned at the beginning of today's session. You can feel free to subscribe and follow either to stay tuned. Really, the only difference is that our email listserv is something sent weekly, and our flyers are sent just a few days before each session as we move past them. But that is all other reminders I have to say. I do want to thank you, Dr. Kittleson, for gathering this presentation, for all the wonderful answers you had during our Q&A. Very, very insightful, I have to say, especially the cases. Just a really great take on them. And if we can hear some thank yous in the chat for Dr. Kittleson's effort with today's presentation, I do really appreciate it. And on the behalf of other students, I'm sure that you appreciate it just as much. So thank you for your time.
Thank you. It was totally a pleasure. Wonderful to be here.
All right. Well, I hope everyone has a great rest of your evening, and we will